Great. Well, thank you so much. Thank you all for being here and for your interest in a topic related to health economics. Except for pandemic times, it's sometimes at the periphery of economics and understanding of systems, but we know these issues can be very important, and indeed they are for China. I have the privilege of working with many co-authors. This particular study is joint with two PhD students at our own econ department, Hui Chun, who graduated pre-pandemic, and Hui you'll be hearing from shortly. And our other co-authors here are all from the Zhejiang CDC, our collaborators there in Zhejiang province, both at the provincial level and in Tongxiang, which is the area that we study. So here we're looking at the effects of chronic disease management at the primary healthcare level. We're looking at a county and looking primarily at the rural population there. It's a primarily rural county. And we want to provide some evidence about this topic because it is so important, although it flies on, doesn't grab the news headlines, flies under the radar, but it creeps up on you, as we know from the latest census and so on, that you've been able to see China's population aging and the pace of that aging for quite some time, but the implications for all of society and for adjustment of the health system are unfolding as we speak. And China has put in place a system of universal health coverage, but within that has also been trying to figure out how best to manage a population which is aging much more rapidly than what the pace that we consider rapid here in the US, not quite as fast as South Korea, but a much larger population at lower per capita income, not the oldest age structure that would be Japan, but approaching it quickly. And part of that is that the primary health burden, as you all probably know, other than during a pandemic, is from chronic disease or chronic non-communicable diseases like hypertension and diabetes, what we'll be talking about today. So that's the dark blue portion here. And you can see even in the lowest income countries, that portion is increasing and projected to increase further. Infectious disease has been largely under control and brought under control, as well as nutrition and many other burdens on health in China. And because of that triumph of controlling other burdens of disease, increasingly the main issue that the system is confronting is managing individuals that are have a chronic disease or trying to help them prevent developing a chronic disease, or once they have it, prevent developing complications. So in collaborating with colleagues in Zhejiang, I talked with the people there, worked with their chronic disease management division within the provincial CDC, and talked with them about what are some of the programs that they have in place, what are they interested in learning about. And this, we mutually decided, was a very important topic to look at, the initiative to try to use primary health care, that's sometimes called grassroots level healthcare in China, to manage older adults with chronic disease. And this is a health system reform or an effort that health systems around the world are undertaking, primarily because that first contact care closer to home is often seen as more convenient and more cost effective, because individuals can receive their management close to home. And in some systems, those close to home providers are even deputized by the system and with incentives to act as a gatekeeper, so that they provide referrals and have to provide referrals if the individual wants to receive covered treatment for any specialist care. China has not embraced this approach. Yes.
I ask a question. So some basic question, I don't know much about this. So what's the percentage of people who are getting this chronic disease? Do all of us have to have some in the future when we got old? What will be the cost as a percent of total like medical expenses in the country? Is that 50%? I mean, what's the
on chronic diseases?
Yeah.
As a whole?
Yeah.
Oh,
any country.
Yeah, well, it depends a little bit so a stroke, it might be an acute episode, but a stroke is a common complication of having heart disease and diabetes, right? So it's a little bit an accounting exercise, but most people would say 70-80% of total spending is related to some underlying chronic disease. Hypertension is a leading risk factor in China and long-term preventable cause of mortality, and has been for well over a decade. Any other questions?
Yeah. Just before we get into it, you're talking about barefoot doctors and them, especially, as them as a potential gatekeeper into the system. I'm assuming you know the work of Sean Sylvia and his colleagues, where basically what they, to put it very simply, right? It's if you get sick in China, try to avoid a village doctor because the probability of being hurt is higher than the probability of being helped. And they also don't like to refer because they like to treat them themselves. There's not a referral fee. So in this area, and of course, most of Sean's work has all been in central and western China, right? So in this area, are these barefoot doctors like really doctors, or are they junior high grads that are running their own little business? Even though it's not to say they're being, they care about their villagers, but they also care about making a living. So do you know how you can characterize that, or
Yes,
are you going to do that
yeah.
in the thing?
Yeah, well, thank you, Scott, for teeing up our question perfectly. You highlighted why this is so important for China, right? Because most individuals don't trust their local primary healthcare provider, and for good reason. Particularly in rural China, there are many reasons not to go to the village doctor first with your precious single child, but also for your grandmother or anybody else, partly because although there's a strong tradition from the barefoot doctor era, China is a quite different society and economy now, and has developed a hospital-based healthcare delivery system. So one of the issues with primary healthcare is seen as cost-effective, but as low quality, and people don't want to use it. So there are a lot of people in primary care, a lot of village doctors, township health centers, where people are sitting there and not seeing many patients. There's a lot of just latent capacity and inefficiency because patients, if they have a choice, are going to flock to what they see as higher quality care, which might be a county hospital outpatient department. And so that is exactly the conundrum that China was trying to address with these kinds of reforms. So as Scott and others,
and that would characterize Tongxiang too. I mean, even though it's this very wealthy part of the Hangzhou Triangle, and but you'd say that would characterize those village doctors there also.
Well, I mean, there have been improvements, and we chose this area not because it's necessarily representative of all of rural China. Indeed, we know it's not. It's representative of rural China maybe 15, 20 years from now, maybe, if there's a lot of progress, right? It's one of the wealthiest parts of rural China. It's been supported in investing in its basic healthcare system. So if you can convince patients there to use primary care and show they're actually receiving decent management of their care, then it's proof of concept that there might be some hope in the future for other parts of China. That being said, these primary care physicians, there's also turnover. Those older barefoot doctors are gradually retiring. There's a question about who's going to be recruited newly into these areas. But the main question we look at is whether you can look at the existing physicians in these areas and utilize that latent capacity to manage individuals with chronic disease. So as you may know, there's a 3-tier healthcare delivery system, hospital-based care for many services, but the grassroots, what we would call here primary healthcare in the rural areas, are the township health centers, obviously in each township, and then village clinics, which in this case are also managed through the township health centers and the physicians employed through them. China has reached universal health coverage using subsidized insurance for rural residents and urban residents without formal sector employment. And then mandatory coverage for employee insurance. We're not going to be talking about that here today. This area of China, Tongxiang and Zhejiang later, is one of the pioneers in a rollout of reforms, which has gone nationwide, is close to universal now, where the two voluntary subsidized forms of insurance that are less generous, the NCMS and the urban residence programs, are merged into a single risk pool. And we just call that residence insurance. That's what it's called, 居民医保. And so enrollment in these programs is quite high, partly because it's subsidized and quite accessible, partly because local officials have incentive to keep enrollment up. And so it's over 95%. And as we'll show you, there actually is a lot of similarly high enrollment in the primary healthcare management programs in these areas. We'll get to that in a moment. These insurance programs provide more generous coverage for primary healthcare, but there's free choice. China's never reached universal health coverage or controlled costs by forcing patients to first go to village doctors or be gatekeepers. That's not part of this reform. It's not on the agenda in China in general. So what they're giving is incentives at the primary care level to see if those village doctors and township health centers can attract and retain patients, even though patients can vote with their feet and go directly to the hospital anytime they want. So this was part of national health reform in 2009, which was just part of an ongoing process. We can talk more about that if you're interested. So just to further highlight before we get to the specifics of our sample, as Scott was teeing up, patients can self-refer, and 84% of China's rural doctors did not have a college degree. So there are reasons why patients flock to large hospital outpatient departments. And there's a lot of latent capacity at the village and township level. So as health economists or economists in general, you could have predicted what many people did not necessarily predict in China, was that once they put in place insurance coverage, this Kanbing-9, Kanbing-Gui problem was even worse, more exacerbated. The hope was by investing in primary care to reduce that crowding. But once you give people better coverage or lower their out-of-pocket costs, or referring to what they see as a higher quality provider, unsurprisingly, that's what they do. So if you look at this blue line here, you can see the share of visits for care, chronic disease and otherwise, has gone down over the period that China was investing in primary care, partly because overall utilization was increasing dramatically and decreasing at a much higher rate for hospital outpatient care. So swimming against the tide, places were trying to invest and strengthen their primary care, and that's what we studied in this paper. So we're trying to evaluate two particular programs that we'll jointly call chronic disease management, one for hypertension and one for diabetes, in the rural Chinese county Tongxiang. And we look not only at use of healthcare, but on patients' health and outcomes. We put together data across the county in different pools of data that are not often linked, from the records of visiting these primary healthcare providers, as well as the medical claims and the health checkup. And around 70,000 individuals in this program. We do a boundary design, Hui will describe in more detail. So it's around 12,000 on which we're developing our more causal estimates. As mentioned, we're looking at both at healthcare use, in particular whether better management of primary care reduces admissions. Inpatient admissions for hypertension or diabetes are often used as a proxy for the quality of primary health care because they're considered avoidable admissions. So that's one thing that we're looking at. And then we look at health through blood pressure and blood sugar control. So I will now turn it over to Hui.
Thank you, Karen, for the great motivation and overview. So I will take from here to describe in detail what we did in the paper and what we found. So before that, a few more things about the setup. This project we study is launched in Zhejiang Tongxiang, which is a high-income rural county in eastern China. The total population in 2015 was about 690,000, and about 80% of them is having rural hukou. And by saying that this is a rich county, its annual per capita income is about 27,000 RMB in 2015, which is more than twice of the national average for the rural population. So as Karen said, this is probably a not representative sample for the total, for the national rural population, but more like more like 15 or 20 years later, what China will be looking at in providing healthcare for the rural areas. And within this Tongxiang County, there are 12 townships, and these will be the administrative boundaries for empirical design. And within these 12 townships, there are in total 209 villages, and we'll be selecting from these a subgroup of border villages for our boundary designs. So the program was launched under the guidelines of the 2009 National Health Reform. And the first stage of the program involves a population-wide canvassing and screening to identify existing patients with hypertension and diabetes and enroll them to the program. And then over time, newly diagnosed patients will be referred to the program after they've been diagnosed during a health checkup or during hospital visits. And once the patient was enrolled in the program, they will be assigned to a specific primary healthcare physicians, or we call it responsible physician or 责任医生. And these responsible physicians are required to meet with their patients at least quarterly and to record their vital statistics, monitoring blood pressure, blood glucose, and provide advice about medications and lifestyle, etc. And these services for enrolled patients, they don't need to pay extra costs for these. Instead, the project is funded by the government and Central Public Health Service, or 基本公共卫生服务基金. And then to monitor the program, Tongxiang CDC, the Center of Disease Control and Prevention, evaluates each township's performance, and an overall performance score will be announced annually as a reputational incentive. And then there is also this financial incentive since 2014, where Tongxiang CDC will launch designed a payment difference to the township health center to motivate the program better. So as we said, this program was administered at the township level. So that is how we construct our boundary designs. So starting in 2009, the program was expanded gradually over the time. And the timeline and effort differs across townships. So we see this difference in the average management duration across each township. So in this figure, each bar here represents either diabetes or hypertension management program in each township. And we keep the names of the township anonymous, but assigning a numeric ID from 1 to 12 for the 12 township within Tongxiang. And the y-axis shows the average management duration in 2015. So here in each township, you see the average duration for hypertension management program is longer than that for diabetes management program. This is because this primary healthcare program was launched first focusing on hypertension and then followed by a program for diabetes. And then across townships, we see that the average management duration ranges from about 2.5 years to at most 4.5 years. And we argue that this difference in management duration is not due to differences in the stock of primary healthcare physicians. So in this figure, we show the number of physicians per 1,000 residents in each township over years. In each subplot here, it is one township labeled in the same way as the previous plot from 1 to 12 township. And for example, if you compare township 1 and 2, which is having an average hypertension management duration of 4.3 years and 3 years, their stock of primary healthcare physician actually doesn't differ very much before the program. And also, this physician capacity measure did not change very much during the program since 2009 to 2015, which is the end of our study period. So we argue that this program is more about incentivizing the existing workforce to provide a better management service rather than more about like more physicians lead to better service kind of stories. Okay, So now let me briefly introduce the data. There are in total 4 data sets that we use to construct the sample. The first is a population database, which is covering all residents in Tongxiang, providing information about their age, gender, education attainment, hukou status, their residential village, and also a death record. So from this population database, we draw our baseline sample, which includes all rural residents above age 40 in 2015. And then we merge that to the second data set.
So Hui, where did that data come from?
So this data comes from the collaboration with the Zhejiang CDC. The population database and PHC management profile are the profile for the total population database comes from the total population who has a record for their medical insurance, etc. And then the PHC management profile comes from the managed program. Includes all of those people enrolled in this. But Karen can correct me if the data collection period has any detailed information about where they come from. The second data set is about PhD management profile. They provide information about date of diagnosis, date of enrollment, and also the responsible physicians each patients are assigned to. So combining these 2 data sets, we get our PHC sample, which includes the rural enrollees to the program above age 40 in 2015. And then, so one of the concerns that would be raised about the program and also about our study is whether there is selection in enrollment. For example, whether the program is only enrolling patients that are easy to manage. Luckily, we're able to link the PHC profile with a surveillance database, which covers all diagnosed cases for diabetes. So comparing these 2 sources of data, we see there is only a relatively small share of diagnosed patients, about 10%, that are diagnosed with diabetes but are not enrolled in the PHC management program. And moreover, this diagnosed but not enrolled patients are on average younger, more likely to be recently diagnosed, live in the urban areas, and also healthier based on their health checkup records. So I argue that the selection is rare and there is less problem of cherry picking in the selection.
Where does this diabetes surveillance data come from?
My understanding is that they come from a different systems other than the management program, but it's also under Zhejiang CDC. Is that correct, Karen?
Yes, right. One reason why we collaborate with Zhejiang is, you all may know this, they have great data management, including in their healthcare system. And one thing that they have is surveillance of important chronic diseases across the whole province, and excellent sort of management of that data and reporting by different localities. So that surveillance data really includes all the people are diagnosed. I might note, however, there are lots of people in China that do not know they have the disease. So the people that are not yet diagnosed, of course, will not be there. But Zhejiang also has above average nationally a rate of diagnosis for these chronic diseases.
One more question for this. So is this like surveillance is from hospitals or from the self-report from the patient or from the clinic, like the village doctors who manage this patient so they can have like this diagnosis records?
The surveillance data comes from the provider that diagnosed the patient, right? So patients may not know if they have the disease, but once they've been officially diagnosed by any provider anywhere in the province, it's part of this surveillance system.
Thank you. Yeah,
thanks for the question. So the other 2 data sets we use are insurance claims data and health checkup data, which are used to construct our outcome variables. So for the first one, the health insurance claims data, it covers, again, all patients enrolled in the management program, and it records information about inpatient admission, outpatient visits, and prescription drug claims. For each of those records, it records date of service, hospital ID, procedure codes, drug codes, and also payment. But I need to note here that for the drug information like dosage, it is only available in 2015. So using all of those information, we construct our outcomes on healthcare utilization. Variables like whether the patient used any inpatient admission in a given year, their total medical spending, and also spending for inpatient, outpatient services, and spending for drugs, and also number of visits to primary health care providers like village clinics or township health centers, and also a number of visits to specialists, which will be the visits to county hospitals or higher level hospitals. And also for the drug or medication records, we construct a dummy indicators for any hypertensive or anti-diabetic drug use, and an intensive margin for that, conditional on using these drugs, how many days they are covered by this medication, but only for the 2015 year. And then the second set of data, which is on the health checkup data, it covers all residents who participate in voluntary health checkups in the year 2013 to 15. And during these health checkups, there will be records or readings on their blood pressure and blood sugars. If someone is taking multiple records and multiple health checkups during these years, we'll take the average measure of those records and construct our outcomes on whether they have their blood pressure or blood sugar under control. Yes, Scott.
Yeah, no, I'm trying to think ahead. I mean, one of the things that, I mean, Shihao could probably tell you a little even better, but one thing that happens when they're looking at hypertension or diabetes, the poor doctors, they don't even, you know, so you go to this doctor and they misdiagnose, you know, and so you aren't even seeing that. And so if we're looking at differences in the number of years that you've been in the program, and there's some, you know, basically the towns with the poor doctors in them enter later, because you don't know if these guys are actually hypertension. We're not only missing the guys who don't come, we're missing the guys who are misdiagnosed. So how do you handle that? Or is that just part of the error?
I would say, yeah, we cannot observe people who are never diagnosed, not in our management program, not in the surveillance data. Just those are the errors that we don't know. What we do know and we focus on is for those diagnosed patients, whether they have better health status and also how their healthcare utilization changes. Yeah, thanks for flagging that. But yeah, this is what we have, and to ask me the causal effect of this management program on those diagnosed patients. Sorry, is there a question?
It's just a quick question. So, what is the major hypothesis here? Is this evaluating different systems, or is there underlying like economic or any hypothesis?
Yeah, the main question we're asking here is whether better primary healthcare chronic disease management program is leading to better health. And
how do you define better? So better program.
Right. Yes, we'll talk about that in a minute. We'll define this management intensity measure, primarily based on the management duration, but we'll also check whether that is correlates with the evaluation score, like an overall effort and overall performance of the program. And that is how we define better here. So like more intensive management program.
So are you going to go look at these, the management intensity, the management length of time? Are you going to look at that look at the characteristics of those towns? I mean, do we see that the towns that started earlier are the suburb towns of the county seat, while, you know, the towns that started later are out there, you know?
Yeah, we do have a comparison or balance check for whether the high management townships are more likely to be in the center or other characteristics. But the design here we're using will be comparing neighboring villages across township boundaries. So the hypothesis here is that by using this identification strategy, we are keeping environmental variables, demographic characteristics, and also access to hospitals as much similar as possible, and then to only look at the difference in management intensity exposed to these boundary villages because they are belonging to different townships.
But you gotta ask why did this one start 5 years ago and this one start 2 years ago? And they're managed at the town level. So,
Right.
you know, that we have better doctors, so we do it first, and we have poor doctors and we wait until we get pushed into doing this. I mean, it's a township characteristic, right?
Right, yes, it's reflecting some of the township characteristics. How can we find out what township characteristics they are reflecting? I think we did some of the survey with those CDC person, and maybe Karen had good stories for this as well. My understanding is that it is just the township health centers decide themselves whether this is the focus of that year or they want to push it to the later years to expand the program.
Excuse me,
Sure.
can I ask a question?
Sure, of course.
So you mentioned that earlier, so this reform actually has a bundle of policies. So even if you compare adjacent villages, how can you assure that, for example, there are, you know, follow-up or other policy at the same time that treat these neighboring villages very differently?
Thank you. That is a great question. We cannot rule out that completely, but just as by talking to the people administrating these, we're not sure that there are policy changes that is happening. First, administered at township level. Second, at the same timeline as different townships launching these programs. So that it's our assumptions here, but we cannot fully rule out that hypothesis. We did some checkups, like for example, whether they have changes in physician stock that is not changing due to these programs. But yeah, that is all we know from the data. And all the other things is based on talking to the policymakers and there. So back to the slides, we have this boundary design. The idea here is to compare neighboring villages across township borders so that we are comparing people with similar demographic characteristics, similar exposure to environment and access to care. And also important aspect of that is they are under the same insurance coverage, but they're exposed to different management intensity because they belong to different townships. And to do this, the first step is to select our border village. And to do that, we're selecting the village with a population above 200 and the pairs whose centroids located within 2 kilometers between each other. And we also drop those village pairs that belong to different townships, which is one traditionally rural township and one traditionally urban township, to avoid any potential difference from those pairs. So this might be clearly seen in this map, where we have the boundary for 12 townships. For example, Wutong and Fengming are 2 townships here. And then we select, based on the selection rule in the previous slides, that leaves us 27 villages in 14 village pairs. That is shown here in the yellow dots across the township boundaries. There are only in total 27 villages in this 14 pairs because there are 3 villages across this Wutong Fengming township boundary that locate close to each other. So it's not 28, but 27 villages in total.
So, so why didn't you include these? Why didn't you include the Puyin village that's right next to the Ugung village? Or the Puyin village that's next to the Longxiang villages. That looks like as close a pair as over there.
Yes, exactly. So that belongs to the rural and urban township pairs I was talking to. The 3 traditionally urban townships or neighborhoods are Longxiang, Fengming, and Wutong. And then the rest of the townships, 9 townships, are the traditionally rural townships. So for example, these pairs over here, they are close to each other, but we are not including them since we are trying to avoid any difference between these Longxiang and Puyin.
Even if Puyin had implemented it for 5 years and Wugong had implemented it for 1 year. I mean,
yes.
Even if there was intensity differences from these townships, you didn't include them.
No, we didn't include
It
that.
seems to me the intensity, I mean, that would what you'd want, right? I mean, maybe these guys all went first and these guys all went second, but it seems like you'd want the identical pairs that in one that have the same, because they probably have more similar doctors, and if one did it longer than the other, that's what you want, right? Is the intensity, you're looking at the intensity of the
right. The intensity of the management program is the variation we want to look at. The variation on unobservable factors that we want to exclude will be the difference between Longxiang and Fuyuan, because one of them is more urbanized and the other one is more rural areas. So that's the reason we drop those pairs. Okay. So with this border villages, we have this border village sample.
Can I ask a question? Very quick
Sure,
question, just out of curiosity. Why do you use 2 kilometers like as cutoff?
It's kind of arbitrary and subjective. We'll sorry, we don't have that in the slides, but we have in the paper just robustness checks of changing the threshold from 1.5 to 3 kilometers, etc. But yeah, the idea here is to keep it close enough so we have this neighboring and comparative sample across the townships, but the 2 kilometers threshold is kind of arbitrary. Thanks for pointing that, and yeah, please check the paper for those results as well. Yeah, so I guess we're good now for the border village sample. The next thing we want to construct to facilitate this boundary design is a management intensity index. To construct that, we use the full PHC sample, which includes both hypertension and diabetes management program in all of those villages, not only the border ones. And we regress each enrollee's management duration, TI, on their patient demographic characteristics, indicators for whether they're in the hypertension or diabetes program, and also the measure of physician stock, number of physicians per 1,000 residents in each township in 2010. Then we take the residual term here, eta I, and take the average at village and township level to be the management intensity score. So we think this score reflects differences in management duration that is not attributable to physicians' characteristics like their chronic disease condition, their age, and their other factors, other observed factors related to demand. And also it's not attributable to existing provider workforce in each township. Instead, this average residual term or management intensity score is capturing the effort in operating the program. For example, as Scott mentioned earlier, like the characteristic of the local leadership, the team dynamics of this PHC management program, and like the recommendation from residents about their satisfaction to the program. And to check the validity of this boundary design, we test whether there is any discontinuity at the village level across the township border. So in this plot, we show a bin scatter plot of village management intensity score against villages' distance to township borders. So for each township border pair, like Wutong to Fengming, we calculate each village's distance to the border. We keep villages that belong to a high management intensity township to the right, with a positive distance to the border, and then the villages belonging to a low intensity township to the left with a negative intensity, negative distance to the border. So the absolute value on the x-axis reflects the actual distance to the border. And then the y-axis, we show the average village management intensity score at each distance bin. So the takeaway from this picture is that there is a jump at the township border, which is confirming that the border villages are exposed to different management intensity. Okay, so with that border village sample and this management intensity score, we can run our regression to estimate the effects on patients' outcome. The first set of outcomes we look at is our healthcare use. So for these outcomes, we estimate a first difference regression where the outcome variable Y is change in healthcare utilization from 2011 to 2015 for a patient I living in village J, township K. And then the key independent variable here is PHC rank. which is the rank of township management intensity score, from 1 being the township with the lowest management intensity score to 12 being the township with the highest management intensity score. So the reason of using this rank variable is that this term reflects the overall management intensity instead of only the duration of the management. We show in the paper that, for example, townships with higher management intensity score also receive higher evaluation score in the CDC assessment, which is based on things like whether the physician is performing according to guidelines, how many follow-up meetings they arrange with their patients, etc. So we believe that this management intensity score reflects the overall efforts into the program, and with the rank variable, we can better interpret the coefficient beta I here as the effect of management intensity when the township management intensity rank is higher by 1. But also in the robustity checks, we show results that is using the continuous version of those intensity score, and also things like leave 1 out median of those scores. Okay, and beyond this PhD rank, we also include a set of controls for physician characteristics and physician capacity controls, similar set as we use to construct the intensity measurement, and also a fixed effect for each pair of the border villages to make sure that we're comparing differences within the border village pairs. Okay, so let's look at what we find. So the first thing in terms of inpatient admission, we find that township management intensity rank higher by 1 is leading to 0.258 percentage point decrease in the probability of having any inpatient admission. Another way to look at the relative effect is to compare a median town to the best performed town in this management intensity spectrum. We call this medium effect because it's medium comparing to the best performed one, which can be calculated by multiplying 6 to this coefficient, and it gives us about 1.5 percentage point decrease, which is about 11.7% relative to the average inpatient rate. Okay. In terms of the total expenditure, total health expenditure, the medium effect is that better management program is leading to 3.6% decrease in total spending. And that total spending reduction is mainly achieved by savings from inpatient spending, but outpatient and drug use, we don't see much changes there. And finally, we see that the PhD management program decreases the number of visits to specialists, which is visits to county or higher level hospitals, but increases the visits to primary healthcare providers, like township health centers or village clinics. And we do this analysis for the pooled sample for both hypertension and diabetes together, and also separately for the hypertension management patients and diabetes management patients. We see similar findings across these samples, although results for diabetes sample is a little bit noisier because the sample size is really small there.
Excuse me, can I ask a question?
Sure.
Sorry if I missed this, but can you explain more about what actually management duration means and matters?
Oh, sure, the independent variable.
Yes.
Yeah, that is the residual term of average management duration controlling patient characteristics and physician supplies.
Yeah, the average duration, does that include how long the patient will be treated by the doctor?
Yeah, it is including the year since diagnosed and the year since diagnosed square term.
Yeah, I was wondering if this is correlated with some other dimensions of this policy. Say there are zero markups, where basically the reform try to reduce the marginal cost for this admission or inpatient or outpatient.
Mm-hmm.
But I see your results also show that by the total expenditure, actually there's no significant change. So does that mean that patients, although they can get, for example, medicine cheaper, but at the same time they may get unnecessary or I don't know additional healthcare that they don't need.
We'll
that
show the
increase their, so that's related with your management duration, right? Construction of your XY.
we'll show the outcomes on medication in details later. So probably that answers your question. Just 2 slides delayed. Thank you. Yeah. So about the medication, again, we only observe the detailed information on that in 2015. So instead of a first difference regression, we conduct a cross-sectional estimation where the outcome Y here is like any antihypertensive or any diabetic drugs in 2015, and also conditional on using those drugs, number of days covered by it, again, in the year 2015. But we do try to control for baseline health status by adding a control term in 2011, one for total medical spending and inpatient admission indicator, one for total medical spending and one for inpatient admission indicator in 2011. So another thing about this medication results for analysis is that we don't see detailed information about we don't see any information on whether the patient is taking the drug on time. We only observe when they are filling the prescription. So we assume that they are finishing their previous fills and then go for new ones. And we also assume that they have this average per day dosage, so kind of ignoring any differences in their disease severity. So by all these, we want to say that this is not the perfect measurement, but this is the best we can do with the data. So here are the results on medication. Perhaps due to all of those potential measurement issue, we don't see any significant effect of PHC on the take-up of antihypertensive drugs and also number of days covered by these drugs. But we do see some suggestive evidence that PHC management program appears to lead to fewer patients taking the drug, but conditional on taking the drug, slightly better adherence for anti-diabetic drugs. So this result is again seen for the diabetes management patients, but also for the hypertension management patients. For one thing, it's partly due to that there are overlaps in these 2 programs. About 15% of hypertension management patients are also in this diabetes management patient program. But for the other thing, if we do trust these results, it is suggesting that PHC program is not overprescribing those medications, but is helping patients to have better adherence for fewer basic medications through regularly interaction and also by providing advices. So these are our findings for medications. Is that answering the previous questions about it to some extent?
One question for this.
Sure.
Is this possible because like the primary care PHC, they do not have access to those like diabetes or hypertension drugs, like prescription drugs, like so they cannot prescribe any like related drugs?
So you were saying after the for example, no drug markup policy, they lack the access to like adequate basic medications, or is there any?
Maybe, yeah, that may be a like main cause of like they lack access to those drugs. But on the other side, like I think they also think about whether they are like profitable even before that policy, because this is a kind of older data. But if it's like not that profit for that one, or like they just cannot get access to those, I don't know whether you have any information on that to explain their prescriptions, not because they do not have drug these 2 disease related drugs, so they just cannot prescribe.
So to my understanding, by looking at data, it also includes prescriptions at the pharmacies, not only the hospitals and primary health care centers. So I don't think it includes that kind of explanation if the patients can go to the pharmacy to get the drugs.
Right, but when primary physicians can't prescribe the drugs,
they cannot get it.
and earn the profits from those drugs. They don't prescribe them often. That's what how it's saying.
Yeah, but those incentives are uniform across all the providers in all of the less intensively managed and the more intensively managed. All the incentives are the same to all the physicians, right? I think maybe you're also referring to the essential medications list differences. And first of all, they were less strictly enforced in some places because patients needed to refer. Also, you'll see that these patients managed in primary care do also occasionally go to specialists. So although they go to specialists less often, they do. If you saw in the diabetes management mean, there's still 3 visits at the specialist level per year. So it's not that they don't have access. Patients can always self-refer there. It's just they're more likely to be receiving and adhering to what they're prescribed in primary care.
Okay. There's a question from Tom Finger.
Thank you. This is fascinating, and I'm not trying to ask an unfair question, I don't think. But if I were a health administrator in China looking at the results of this work, what would I conclude? That it's working okay, I don't need to do anything in particular, or that I have a problem, and the problem that I most need to focus attention on is X? What would be the answer to those questions?
Yeah, thank you for the question. So we have another one set of results I would like to show, and then we'll conclude with the answers to your question. Is that okay?
Sure.
Sure. So the last set of results is on health outcome, which is important for like policy administrator to evaluate this program. So for the health outcomes, it is drawn from the health checkup data, but you only have that from 2013 to 15. So we look at both a cross-sectional regression and a first difference regression. And the first one, the outcome is whether the patient is getting their blood sugar or blood pressure under control based on the average biomarkers in all of those 3 years. And in the second, we use a restricted or limited sample of those patients who have both health checkup in 2013 and 15 and look at their changes in the indicator of blood pressure and blood sugar under control. So what we find there is that first, again, noted that the health checkup it's voluntary. So there is a difference. There is an effect on management program on the take-up of this health checkup. For example, this means that there will be some selection problem if we only look at the cross-sectional results, but it's less of a concern for the first difference regression since we are looking at the changes of each person. And then if we look at the blood pressure under control indicator, we see that PHC management program increases the probability of having blood pressure under control, both for stage 1 and stage 2 criteria, and both for cross-sectional and first difference regressions. And if we want to look at the medium effect based on column 6, since we trust the first difference regression more or better, it is saying that the probability of having blood pressure under control for stage 2 criteria increases by 12.2 percentage points, while the raw trend is from the 2013 to 15 is showing an about 6.4 percentage point decrease in the average control rate. And then for the fasting blood sugar results, it is less encouraging since we find some evidence saying that better management intensity is leading to a decrease in the probability of having fast blood pressure under control, especially for the hypertension management patients. So with this suggesting that there is a multitasking problem, for example, the hypertension management programs focuses more on blood pressure, but doing that at the expense of not monitoring blood glucose better, we raise that potential concern, but the data, it's not that precisely confirming that problem. And also we need to note that fasting blood sugar itself is more problematic as a measure because we don't know whether this blood sugar readings are taken actually before eating or something. So these are the 3 sets of results we find. so to answer Tom's earlier question, the takeaway from the paper is that we find that the PhD management program is doing better, is having a benefit on patients' health, although kind of the multitasking problems, and they're doing so not at the expense of using too much of the resources, because people are using the primary health care more and not using specialist visits, and also they're reducing the avoidable admissions at the inpatient department as well. But we raised some problems here, like the fasting, the multitasking problem for blood sugar, and also the medication thing. That is the point. That are the areas for the future policy designers and also researchers to think better.
Is it possible that they're just misdiagnosing this as blood pressure under control, and so they're missing that this is a diabetes problem, and so that's why they're sort of, you know, putting lots of effort into blood pressure control, but then missing the
and that is the hypothesis we're listing here as the multitasking. They're missing the control or surveillance.
So it's just bad. It's just poor quality of healthcare providers.
Yeah, it could be.
Well, multitasking in the sense, if they're rewarded and focusing on managing hypertension, they might not be focusing on diabetes. That doesn't mean that they're poor quality overall, right? They could be. They are not qualified to perform open heart surgery. They are qualified to measure blood pressure and blood sugar, but they're not doing the latter as much as maybe they ought to be.
But a good doctor, but wouldn't a good doctor do that?
Yes, indeed. And so some, as we noted, that the overall challenge in the US as well is that your doctor doesn't always measure your blood pressure or your blood sugar. Sometimes you don't find you have the condition until symptoms have already developed. Yeah.
Hui, and then
so Hui, I have two questions. So the first one is that maybe I'm slow, like but when you construct the PhD rank, do you consider or account for the joint time that both program, diabetes and high blood pressure problem, like both surveillance program, like in place in the county or in the township?
Yes. So for the main analysis, we do this for the pooled sample of hypertension, diabetes, but we do have indicators for whether this patient is listed in the hypertension program or diabetes program, considering that hypertension is launched first. So if they're in the hypertension program, they're more likely to have a longer duration. As the robustness checks, we do this separately, constructing the intensity measurement separately for the two programs, and then regress the respectively for the effects in hypertension, diabetes.
So my point is, does it make sense to create a indicator for both program in place? I mean, interaction of two indicators when you're constructing this rank, so that when, say, if we have two programs in place, maybe treating one will kind of like treating, like if a patient has a blood pressure problem, maybe they also have a high blood pressure problem, so that having two programs will benefit them.
Yeah, that's a very good point. We don't have the interaction term here. Yes, so that's a great point to consider. We don't have that in the current analysis.
So my second question is that whether it makes sense to take out those like villages comparison, like in a urban to urban cases, only compared to rural villages on the border. Does it change the results? Or like maybe if you can show us like what's a PhD rank of all the counties, like by their rural urban like region, maybe it will kind of tell more about it.
Yeah, so although the intensity is kind of anonymous, but if you remember those subplot or the bar plots, the 1 to 3 should be the urban townships, and then the rest should be the rural townships. We don't see a distinction between rural and urban that distinctly in those descriptive analysis. I think we did a version that drops all of the urban townships once. It's not included in the final version of this paper, but it's not generating very different results.
Thank you.
How do you have a question?
Yeah, I'm thinking like the results, the difference between hypertension and diabetes. One thing I can come up with, I know like the sample size is quite different for the hypertension and diabetes. And but when I check like the average rate of hypertension and diabetes, it seems like kind of close like to like diagnosis rate. But I'm thinking one reason cause like why there are less diabetes people seems like here is maybe because it's from 2005 to 2015. Then there, I think it's very hard for them, especially if in the primary care, for their to diagnose diabetes. Because they do not have the quick test, or I think like the equipment to do the diabetes test, the quick like a sugar test, blood sugar test. Yeah, but I think for hypertension, I think that machine is very like I think well available in all the clinics, all the hospitals. I think that may be like one possible like explanation, but I'm sure they need more like information or data to prove that.
Yeah, thank you. Yeah, we need to look more into this, but thank you for contributing to one of the hypotheses. But also to flag that diabetes programs definitely launched later as a follow-up program. So it's also true that that would reduces the sample size a little bit. Okay, so
Hui, do you have any concluding remarks? We're getting
down I do have one last thing we want to say about this welfare calculation. We did at this as a conclusion and also welfare analysis about the cost and benefit comparison. So very quickly go through this. We evaluate the cost of program by looking at this government essential public health service budget, applied it to the total population, and also a share of the budget that goes directly to this disease management program. That gives us about 3.09 million RMB spending annually. And then we calculate the benefit of the program by using this estimation on the saving in annual medical expenditure, which is about 80 RMB as the medium effect, and then we multiply that by the total enrolled population, which gives us about the 7 million RMBs. So it is far exceeding the cost of the program. And this is not yet including any values from the improved quality of life and survival. So as the last point is saying that the benefits from cost saving outweighs the cost for this PHC program.
But I think aren't we missing 3% of the or however many percent of the people with diabetes, and are they gonna die because of this? I mean,
we're missing 10% of PC.
Yeah, so is the 10% missing of the diabetes, is that worth 3 million yuan? Right? I mean,
but those are the younger, healthier, right. As we showed you earlier. They are younger, recently diagnosed, and much healthier, living in urban areas. So they're much less likely to die than the older people that are enrolled here, although we don't have the data to prove that.
Okay, got it. No, I thought that was
thank you. Yeah, this is the concluding slides and the takeaway from the paper. Like we documenting China's effort in promoting PHC management for chronic diseases. We we put together data sets, use a boundary design to evaluate the causal impact. This is what we find for the health care utilization and also health outcomes. And finally, we conclude this welfare analysis. Just talk about.
Great.
This is all I have for the slides. We still have 5 minutes or so for discussions or any questions.
Sorry, I have another very quick question. Maybe I missed it. Why did you guys only choose Tongxiang as your sample? Like not like including other like counties in Zhejiang province?
I'm afraid this is the only data we got.
I see.
Which is from the Tongxiang County.
Mm-hmm.
It would be great to have other people look at this question in many different places throughout China. Just throwing in that I've analyzed the Charles Nationally Representative Survey just to say that low diagnosis of diabetes related to hypertension is definitely true there. I know Tom had to drop out, but I wanted to mention this, what the take home might be. So as Hui showed in the slide, I don't know if you saw the mean of the dependent variable for hypertension control, like 55%. Anyone want to throw in the chat, what is the percentage of rural Chinese with diagnosed hypertension where their hypertension is under control? In these areas, it's around 55%. Mean for rural China? Anyone? And it was
70%.
increased.
70%.
Mean for rural China is 6, single digit 6%.
Or under control.
Are under control. Yeah, exactly. So 94% are out of control. Yes. So glass half full, glass half empty, right? So to Tom's question, yeah, this place is doing a lot better, but still it's only a little half of percentage that have it under control.
Thank you, Karen. Thank you, Hui.
Thank you.
Thank you all.